All right, welcome back and get ready, because today we're embarking on a journey to truly master a medical topic that can feel incredibly complex, yet is absolutely vital to understand: osteomyelitis. You know how sometimes you just wish someone could cut through all the noise, distill the most important facts, and serve them up with a side of genuinely fascinating insights, helping you grasp even the most granular details? Well, that's precisely our mission. We're going to dive so deep you'll gain an understanding on par with elite professionals in the field, all drawing exclusively from an incredibly detailed medical source. Chapter 131 on osteomyelitis, from Harrison 250-11619-1746-100.pdf us. Prepare to become truly, comprehensively well-informed.
Indeed. This deep dive will illuminate the multifaceted nature of bone infection, from its varied origins to the highly specific treatments required. We'll meticulously explore not just what happens, but the profound why behind the different diagnostic approaches and therapeutic strategies, dissecting what truly defines success in managing this complex and often challenging disease.
So, to begin, what exactly is osteomyelitis at its core? It sounds like a single condition, but our source quickly reveals it's far more intricate. Essentially, it's an infection of the bone, but it's not, a uniform enemy. It's caused by various microorganisms that find their way into the skeletal system through a few distinct crucial routes. One major pathway is what's termed spontaneous hematogenous osteomyelitis. This is where the infection originates from microbes circulating freely in the bloodstream, seeding the bone from within. What's particularly noteworthy about this type is that it can surprisingly occur in otherwise healthy individuals. Imagine a bacterium from, say, a minor skin irritation or maybe a dental procedure, making its way into the bloodstream, traveling silently, and then finding a hospitable spot within the bone to establish an infection. It's an internal assault, often without an obvious external point of entry, directly related to the bone. Then there's the other predominant pathway: local microbial spread. This route is typically observed in individuals with underlying health conditions that make them vulnerable. Things like vascular insufficiency, where blood flow to certain tissues is compromised, or those with a compromised skin or soft tissue barrier. Think of it as kind of an open invitation for microbes. This often follows significant bone surgery, like a sternotomy — that's a surgical incision made through the breastbone, common in cardiac procedures — or after various orthopedic repairs, such as fixing an open fracture. In these scenarios, the bone is directly exposed, making it an immediate and often accessible target for local infection from the surrounding environment or, adjacent infected tissues.
A truly fascinating aspect here is how the manifestation of osteomyelitis differs significantly between children and adults. It's a distinction that immediately steers the diagnostic approach and raises specific flags for clinicians. In children, circulating microorganisms predominantly seed the long bones. Picture the femur or tibia, the large bones in the legs, or the humerus in the arm. These are often the primary targets for hematogenous infection in a child, leading to pain and swelling in those limbs.
So it's the long bones for kids.
Exactly. But in stark contrast, when we shift our focus to adults, the vertebral column, your spinal bones, is the most commonly affected site for hematogenous osteomyelitis. This anatomical difference is profound. It sets the entire stage for understanding the different types and challenges of this infection. It directly influences where a clinician might first look, what specific symptoms they prioritize, and what advanced imaging strategies they might employ. It's a fundamental divergence in disease presentation based on age.
Okay, so considering these diverse origins and locations, what does this all mean for treatment? Is there a universal aim for tackling osteomyelitis, regardless of how it presents or where it's located? Our source makes one goal abundantly clear, highlighting its overarching importance. The single most crucial aim of management for any type of osteomyelitis is to prevent its progression to a chronic state.
That makes sense. Chronic infections are always harder to deal with.
Absolutely. And this prevention, in turn, is primarily achieved through a rapid and accurate diagnosis, followed by prompt and effective treatment. It's truly a race against time to catch the infection before it establishes a persistent long-term foothold, transforming into a far more challenging adversary. When we consider device-related bone and joint infections specifically, the complexity of this race escalates dramatically. This particular scenario almost invariably necessitates a multidisciplinary approach, requiring not just intensive, prolonged antibiotic therapy, but, in many cases, the surgical removal of the implanted device itself. That can be a huge physical, emotional, and logistical undertaking for the patient, emphasizing the critical importance of early intervention and complete eradication.
This leads us to a critical consideration regarding treatment guidelines. When we look at the broader picture of managing osteomyelitis, it's quite notable that for most types, the optimal duration and even the precise route of antibiotic treatment have not been established through extensive randomized clinical trials, the kind of trials that are typically medicine's gold standard.
Really? So how are treatment decisions made then?
Well, therefore, the recommendations we often rely on reflect primarily expert opinions. This isn't a minor point, it's a significant nuance in medical practice. It means that while there are established best practices and consensus among specialists, these are largely born from accumulated clinical experience and expert agreement, rather than from large-scale, rigorously controlled studies.
Hmm. Why would that be the case? Why aren't there more trials?
Well, consider the inherent complexity and heterogeneity of osteomyelitis. It's not a single uniform disease. It's a spectrum of infections varying widely in location, the specific microorganism causing it, the patient's underlying health conditions, and the critical presence or absence of foreign material like implants. Designing and conducting clinical trials that account for all these variables, especially for the rarer subsets of the disease, would be incredibly challenging. Furthermore, it could present ethical dilemmas, right? Withholding an established, albeit expert-driven, treatment in favor of a trial protocol might raise serious concerns about patient welfare.
Ah, okay. That makes sense. You wouldn't want to withhold potentially effective treatment just for a trial.
Exactly. So, while expert consensus is undeniably valuable, it underscores the ongoing need for continued research to solidify evidence-based protocols wherever and whenever feasible.
It certainly sounds like a disease with many faces, and indeed our source notes there's no single, universally accepted classification system for osteomyelitis. Why is it so difficult to neatly categorize this infection? It's largely due to its multifaceted presentation. You have different medical specialists, an orthopedic surgeon, an infectious disease doctor, a general practitioner, and each might encounter osteomyelitis in a slightly different form, focusing on the aspects most relevant to their specific specialty. This inherent diversity makes a one-size-fits-all classification nearly impossible.
Different perspectives on the same core problem.
Exactly. What's particularly insightful is that general practitioners, or internists, are also the very first clinicians to encounter patients presenting with the initial signs and symptoms. This means they must possess a broad ability to recognize this disease in any of its myriad forms, which truly speaks to its diverse and often subtle beginnings. It highlights the foundational importance of a comprehensive clinical understanding even before specialized investigation.
While a single universal system remains elusive, cases can effectively be classified by various criteria, which then helps immensely for tailored management. These criteria offer different lenses through which to view the infection. They include the pathogenesis, meaning how the infection originated, whether from the bloodstream, direct spread, or another source, the duration of the infection, whether it's acute or chronic, the specific anatomical location, and critically, the presence or absence of foreign material, like an implant.
Right, those seem like key distinctions.
They profoundly impact the treatment strategy. Our source highlights the Cerny-Mater staging system as a prime example, particularly useful for trauma surgeons dealing with long bones. This system classifies long bone osteomyelitis not just by the anatomic site, but also by patient comorbidities, things like diabetes or vascular disease, and detailed radiographic findings. Its purpose is to optimize surgical management by uniquely encompassing both systemic factors affecting the patient's overall health, like immune status and metabolism, and critical local factors, such as the vascularity or blood supply of the affected bone and surrounding tissue.
Wow, that sounds incredibly detailed, very personalized.
It is. This comprehensive approach allows for a much more precise and personalized treatment plan, moving far beyond a simple diagnosis to a nuanced understanding of the patient's individual situation and challenges. This detailed stratification brings us squarely to the fundamental mechanisms of how the infection truly takes hold.
And this is where it gets truly captivating. There are three primary ways osteomyelitis can start, each a distinct pathway for infection. Let's explore these mechanisms in detail because understanding the origin is absolutely fundamental to effective diagnosis and targeted treatment. The first is hematogenous spread. This is where microorganisms travel through the bloodstream from a distant primary infection site and then seed the bone. In adults, as we touched on earlier, this typically involves the vertebral column. But here's a critical, often perplexing point. In only about half of patients, a primary focus at that initial source of infection elsewhere in the body can actually be identified.
Only half? That's surprising.
Isn't it? When they are found, the most common primary foci include infections in the urinary tract, various skin and soft tissue infections, and sites of intravascular catheterization, like where a central line might have been placed. So imagine a seemingly innocuous urinary tract infection far removed from the spine, potentially leading to a severe bone infection in a vertebra. It's a silent, insidious journey for these microbes, often leaving no obvious trail. The second pathway is spread from a contiguous site following surgery. This is essentially direct invasion of infection. It often occurs after significant cardiovascular interventions involving the sternum, like open heart surgery where the bone is opened. It's also a significant risk after orthopedic repair following an open fracture where the bone has been directly exposed, or crucially after prosthetic joint insertion where the implant itself can become a fertile ground for infection.
So direct contact or exposure is the key there.
Precisely. In these scenarios, the bacteria are directly spreading from an adjacent infected area or from external contamination right into the bone or around the foreign material. The third primary mechanism is secondary infection in the setting of vascular insufficiency or concomitant neuropathy. This pathway most often follows a chronic, progressively deep skin and soft tissue infection of the foot. Our source highlights that the most common underlying condition here is undoubtedly diabetes, specifically what's known as diabetic foot syndrome.
Yes, the diabetic foot, a major challenge.
A huge challenge. It's a complex and devastating condition that combines skin, soft tissue, and bone ischemia, meaning inadequate blood supply, with motor, sensory, and autonomic neuropathy, which is extensive nerve damage. This insidious combination creates an incredibly vulnerable environment where a seemingly minor foot wound or ulcer can rapidly progress to a severe and limb-threatening bone infection. Considering the increasing rates of diabetes globally and the rising number of complex and invasive surgeries being performed, it's worth taking a moment to consider the profound impact this might have on the future incidence of osteomyelitis.
Yeah, you'd expect the numbers to go up, wouldn't you?
It's highly probable that we will see a continued rise in cases, particularly those linked to surgical complications and the severe diabetic foot infections we've just discussed. This escalating trend places immense pressure on healthcare systems worldwide to enhance preventative measures, improve early diagnostic capabilities, and foster highly specialized multidisciplinary teams to manage these increasingly prevalent and challenging infections effectively.
This brings us to a very important consideration. Beyond the source of the infection, how does the duration of the infection and, perhaps even more critically, the state of the bone itself influence treatment? Classification by duration, whether acute versus chronic, is indeed useful because the management differs significantly. However, it's vital to acknowledge that the precise definitions of acute and chronic can be somewhat fluid and, well, ill-defined in practice.
So it's not just about how long the infection's been there.
Not entirely. Crucially, what matters more than a strict time frame is the presence or absence of bone necrosis. These are essentially dead pieces of bone, which clinicians refer to as sequesters. This distinction is absolutely paramount for guiding therapeutic decisions. If we are dealing with acute osteomyelitis, particularly when there is no bone necrosis, the infection can generally be treated with antibiotics alone. The assumption here is that if the infection hasn't caused irreversible, devitalizing damage to the bone, antibiotics can effectively penetrate and clear it.
Okay, so antibiotics work if the bone is still alive, essentially.
Pretty much. In stark contrast, for chronic osteomyelitis, antibiotic treatment almost universally must be combined with surgical debridement. This surgical procedure involves meticulously removing the infected, necrotic bone and tissue because antibiotics alone simply cannot effectively penetrate and clear the infection from dead bone.
Right, you have to physically remove the dead, infected stuff.
Exactly. This is a foundational principle in managing chronic bone infections. You cannot leave dead, infected tissue behind and expect a cure with antibiotics alone. To illustrate this, acute hematogenous or contiguous osteomyelitis typically evolves over a relatively short period, often just a few days or weeks, presenting with more immediate and intense symptoms. Subacute or chronic osteomyelitis, conversely, develops more insidiously, lasting for weeks or even months before treatment might even begin.
So much slower onset.
Yes. Typical subacute examples include vertebral osteomyelitis caused by tuberculosis or brucellosis, which often have a slower, more creeping onset, or certain delayed implant-associated infections caused by low-virulence microorganisms like coagulase-negative Staphylococcus or Cutibacterium acnes. These organisms are less aggressive, leading to more subtle, persistent, low-grade infections over time. Chronic osteomyelitis develops when initial therapy has been insufficient, either in its duration or completeness, leading to the persistence or recurrence of the infection. This is most frequently seen after sternal, mandibular, or foot infections, where the complex anatomy or underlying patient conditions make complete eradication particularly challenging.
And finally, how does the specific anatomical location of the infection or the challenging presence of a foreign object guide the overall medical strategy for osteomyelitis? Our source tells us that classification by location clearly distinguishes cases occurring in the long bones, often affected in children, from those in the vertebral column, more common in adults, and the periarticular bones, those immediately surrounding a joint.
Right, location matters.
Big time. Long bones, such as your femur or humerus, are generally involved after hematogenous seeding, particularly in children, or after contiguous spread following trauma or surgery in adults. So a child might get it from the bloodstream, an adult more likely after an injury or operation. The risk of vertebral osteomyelitis in adults, as highlighted, significantly increases with age. This makes clinical sense, as older individuals often have more comorbidities or have undergone more invasive procedures.
Yeah.
Periarticular osteomyelitis, which complicates inadequately treated septic arthritis, that's a joint infection, is especially common in what's known as periprosthetic joint infection, or PJI, involving artificial joints.
The dreaded PJI.
Exactly. This brings us back to the absolutely crucial role of foreign material. Our source emphatically states that osteomyelitis involving a foreign device always requires surgical management for cure.
Always, no exceptions.
According to this source, no. You simply cannot rely on antibiotics alone to clear an infection that has colonized an implant. Even acute implant-associated infections necessitate prolonged antimicrobial therapy, making their precise identification and classification of immense practical importance. Now let's zoom in on what our source highlights as the most common manifestation of hematogenous bone infection in adults: vertebral osteomyelitis. This condition goes by several names: disc space infection, septic discitis, spondylodiscitis, or spinal osteomyelitis. These all underscore a shared process involving adjacent vertebrae and the crucial intervertebral disc between them.
So it's the disc and the bones next to it.
Precisely. What's happening here is quite specific to the adult spine. The intervertebral disc itself is avascular. It doesn't have its own direct blood supply. So microorganisms typically invade the bone via the segmental arterial circulation in the adjacent vertebral end plates, those surfaces meeting the disc, and then critically, the infection spreads into the disc itself.
So it gets the bone first, then the disc.
Generally, yes, in adults. However, our source points out alternative, though less common, routes. Microbes can spread through retrograde seeding via the prevertebral venous plexus, a vein network in front of the spine. And as you might expect, direct inoculation can occur during spinal surgery or after epidural infiltrations or due to severe trauma. In spinal implant surgery, the microbes are inoculated either during the procedure or in the early postoperative period if wound healing is impaired.
This naturally leads us to a critical question. Who is most affected by vertebral osteomyelitis, and are we witnessing an increase in cases over time? The epidemiological data our source provides offers clear insights. It occurs more frequently in males than females, ratio about 1.5 to 1. Perhaps more strikingly, the incidence rate in the U.S. increased dramatically between 1995 and 2008, jumping from 2.2 to 5.8 cases per 100,000 person years.
Wow, that's more than double.
It's a substantial rise. We also see a very clear age-dependent increase. Low incidence under 20, around 0.3 per 100,000, rising sharply to 6.5 per 100,000 for those over 70. So it disproportionately affects older adults.
Any idea why the increase?
Well, the observed increase likely reflects a combination of factors. A major contributor is undoubtedly improvements in diagnosis, particularly from the widespread availability of MRI. Better detection means more reported cases, right?
Makes sense.
Additionally, the fraction of healthcare-associated cases is rising. This is a direct consequence of increasing patient comorbidity, more chronic health issues, and the rising number of invasive medical interventions, each carrying a small risk.
Okay, turning our attention to the microbial culprits, what are the primary pathogens behind vertebral osteomyelitis? Our source says it's typically classified as pyogenic, pus-forming, or non-pyogenic, though it adds this distinction is somewhat arbitrary.
Yeah, the lines can be blurry.
In those non-pyogenic cases, often with a subacute or chronic course, or suggestive history, or specific tissue changes like granulomas, clinicians must specifically search for Mycobacteria brucellii, things like TB or brucellosis. Furthermore, when standard blood and tissue cultures are negative despite strong suspicion, advanced non-culture techniques become vital. This includes things like PCR analysis or even metagenomics on biopsy specimens or pus.
Cutting-edge stuff to find those hard-to-grow bugs.
Exactly. Helps detect unusual pathogens like Helicobacter or Trophorema whippleyi.
Hmm.
It really shows the diagnostic effort needed. Now, the more common bacteria in acute vertebral osteomyelitis, Staphylococcus aureus is the big one, 40% to 50% of cases.
Aureus, always a major player.
Then Streptococci, about 12%, and various gram-negative bacilli make up about 20%, mainly E. coli, around 9%, and Pseudomonas aeruginosa, around 6%. For subacute cases, the landscape shifts, typically Mycobacterium tuberculosis or Brucellus species, especially in endemic regions. Viridans streptococci also often present subacutely, frequently as secondary foci in patients with endocarditis.
So the spine infection could point to a heart problem.
Absolutely, a critical link to investigate. Candida species, a fungus, can also cause it, and diagnosis is often delayed. Suspect this especially in IV drug users not using sterile gear. Finally, implant-associated spinal osteomyelitis. Coagulase-negative Staphylococci and C. acnes are typical culprits. These cause low-grade chronic infections. Interestingly, without an implant, these are often dismissed as contaminants, but on hardware, they're usually significant.
The implant changes everything.
It does. Though there's an exception. Coagulase-negative staph can cause native spinal osteo in cases of prolonged bacteremia, like from infected pacemaker leads or catheters not properly removed.
A truly intriguing aspect here is that the clinical signs and symptoms are often quite nonspecific, making diagnosis a substantial challenge. For instance, only about half of patients actually develop a fever above 38 degrees C, maybe due to frequent analgesic use masking it.
Only half have a fever. That's low.
It is. However, back pain stands out as the predominant initial symptom, over 85% of cases. The pain location often corresponds to the infection site. Cervical spine, 10%, thoracic, 30%, lumbar, 60%. An important exception is tuberculous osteomyelitis. Often thoracic level, 2/3 of cases, lumbar only 1/3. This is due to direct mycobacterial spread via lymph nodes from pulmonary TB.
Interesting pattern for TB.
Yes, neurologic deficits like radiculopathy, weakness, sensory loss occur in about 1/3 of cases. These are mostly caused by a serious complication, a spinal epidural abscess. This typically starts with severe localized back pain and can progress rapidly to radicular pain, reflex changes, sensory issues, motor weakness, bowel bladder dysfunction, even paralysis. It's urgent.
It sounds terrifyingly fast.
It can be. It's always important to search for a primary infection source, but remember, it's only found in about half of cases. Overall, endocarditis is identified in 10% of patients with vertebral osteo, and specifically for viridans streptococci osteo, endocarditis is the source in about half of those patients. So definitely check the heart in those cases.
Got it. What about implant-associated spinal infections? How do they present?
They can vary. Early onset is within 30 days after implant. Psoriasis is common. Leading findings are impaired wound healing and fever, more like a classic acute infection. Late onset is diagnosed beyond 30 days. Low virulence organisms like coagulase-negative staph or C. acnes are typical. Fever is rare, maybe a quarter have a sinus tract. Because of this delayed, subtle course and lack of classic signs, rapid diagnosis of late-onset cases requires a really high degree of suspicion.
Given these often nonspecific symptoms, what does this all mean for making a definitive diagnosis? What tools do clinicians have? Our source details the diagnostic pathway, emphasizing lab and imaging studies. First, blood tests. Leukocytosis and neutrophilia have low diagnostic sensitivity, only 65% and 40%, often not elevated.
So not very reliable on their own.
Not really. In stark contrast, increased ESR or CRP levels are reported in almost all cases, 98% and 100%. This makes them incredibly helpful in excluding vertebral osteomyelitis if normal.
High negative predictive value then. If they're normal, it's probably not osteo.
Exactly. Blood cultures are crucial, but yield varies widely, 30%, 78%, heavily dependent on prior antibiotic use. Given this, the recommendation is strong. Withhold antibiotics until microbial growth is proven, blood, bone biopsy, or pus, unless the patient has sepsis syndrome.
Sepsis needs immediate treatment, of course.
Right. For patients with negative blood cultures and ongoing suspicion, CT-guided or open bone biopsy is needed for definitive identification. Direct sampling is often key. Now, imaging paramount here. Plain radiography, standard x-rays, maybe a reasonable first step without neurologic symptoms, might show an alternative diagnosis or chronic signs, but low sensitivity in acute osteo. better in subacute or chronic cases.
So X-rays are limited early on.
Very limited.
Yeah.
The undisputed gold standard is MRI. Should be done expeditiously in patients with neurologic impairment to rule out things like a herniated disc or detect complications like epidural abscesses quickly. The source shows an MRI clearly depicting inflammation in a small abscess.
MRI gives the best view.
By far. However, a critical point. Even with highly suggestive MRI findings, alternative diagnoses must always be considered, especially if blood cultures are negative. Things like erosive osteochondrosis, septic bone necrosis, gout, Anderson lesions can mimic it.
So MRI isn't foolproof either. Need the whole picture.
Exactly. CT, while less sensitive than MRI for infection itself, is helpful in guiding percutaneous biopsy. Shows bone anatomy well for targeting. Finally, 18F-FDG-TET offers high diagnostic accuracy, an excellent alternative when MRI is contraindicated, for example, metal implants. The source shows a PTCT highlighting uptake, suggesting inflammation, also useful for implants and suspected multiple foci.
Once vertebral osteomyelitis is diagnosed, the treatment aims become clear, but the methods involve careful consideration. Our source outlines 4 other bone loss, 3, relieve back pain, 4, prevent complications like abscesses or instability, and 5, stabilize the spine if needed.
Seems comprehensive. How about the actual treatment?
Regarding antimicrobial therapy, optimal treatment requires identifying the infecting agent and its susceptibility pattern. This is why antibiotics generally shouldn't be given before identification, unless sepsis, as it can muck up the diagnosis.
So wait for the culture results if possible.
If possible, yes. Traditionally, bone infections started with IV antibiotics. However, the source makes an important point. The preference for IV is not evidence-based. Oral administration can be non-inferior if specific requirements are met. Optimal antibiotic spectrum, excellent oral bioavailability, clinical studies confirming efficacy, normal gut function, no vomiting.
Oral can be just as good sometimes. That's huge for patients.
It is. A controlled trial showed oral therapy was non-inferior to IV during the first 6 weeks for bone and joint infections, including vertebral osteo. Very significant finding. Nevertheless, a short initial 5E course, maybe with a beta-lactam, might still lower the risk of fluoroquinolone resistance emerging, especially with pseudomonas or staph infections being treated with combination therapy.
Okay. How long does treatment usually last?
Duration is critical. A randomized trial showed 6 weeks of antibiotics is not inferior to 12 weeks in pyogenic vertebral osteo, with a 91% cure rate after 1 year in both groups. This suggests prolonged therapy beyond 6 weeks is mainly needed only for patients with undrained abscesses or spinal implants.
So 6 weeks is often enough for uncomplicated cases.
Seems that way based on this trial. Monitoring efficacy involves checking symptoms, fever, pain, and inflammatory markers, CRP. Follow-up MRI is appropriate only for patients with complications like abscesses. The correlation between clinical healing and MRI improvement is actually very poor, so an MRI abnormality doesn't necessarily mean treatment failure if the patient feels better.
Interesting. So rely more on clinical signs and CRP. What about surgery?
Generally not needed in acute hematogenous vertebral osteo if caught early, responds to antibiotics, no major complications. However, surgery is always necessary in implant-associated spinal infection. The implant harbors bacteria in biofilm.
Right, the biofilm fortress again.
Exactly. For early implant infections, up to 30 days post-op, cure might be possible with debridement, implant retention, and 3 months of antibiotics. But for late infections, 30 days, implant removal plus 6 weeks of antibiotics are typically required for elimination. Much more aggressive.
Big difference depending on timing. What if the implants can't be removed?
A tough situation. Then long-term oral suppressive antibiotic therapy should follow the initial IV course. Optimal duration is unknown, but close clinical and lab CRP follow-up is crucial if stopped, say, after a year. Goal shifts to control, not cure.
Even with the best treatments, complications can arise. What are the critical warning signs? Our source is clear. Suspect complications with persistent pain, persistently increased CRP, and new or worsening neurologic impairment. These demand immediate investigation.
Red flags you can't ignore.
Definitely. Clinicians must actively seek perivertebral, epidural, or psoas abscesses dangerous pus collections. Epidural abscesses occur in 15–20% of cases, more common in the cervical spine, 30%, than lumbar, 12%. Risk factors for severe neurologic deficit include epidural abscess, cervical thoracic involvement, and S. aureus infection. Persistent pain, despite normal CRP, should prompt investigation for spinal instability. Need an orthopedic surgeon consult then.
Connecting this to the global picture, geographical location plays a surprising and critical role in the types of pathogens. While acute vertebral osteo incidence is similar globally, subacute to chronic cases predominate in specific regions, reflecting local endemic diseases.
Like TB and brucellosis we mentioned.
Precisely. Cases due to brucellosis predominate in the Middle East, Africa, Central South America, Indian subcontinent. Tuberculosis is especially frequent in Africa and Asia, India, Indonesia, China, where most of the global TB burden lies. This means specific diagnostic tests for these organisms are crucial for patients living in or having traveled to these regions. Travel history is vital information. 4. Deep Dive 2. Osteomyelitis in long bones childhood and trauma's shadow.
From the spine, let's move to the long bones, which have their own unique patterns, often linked childhood infections or trauma. Pathogenesis here. Osteomyelitis in long bones results from hematogenous seeding, typically kids, exogenous contamination during trauma, open fracture, or perioperative contamination during surgery involving bone.
So bloodstream in kids, direct contamination mostly in adults.
Pretty much. In adults, the leading source is exogenous infection, mainly associated with internal fixation devices, plates, screws, rods. For classification and surgical decisions, the presence of a sequester, dead bone, and the status of surrounding soft tissue are crucial. Chronic osteo can even reactivate after a symptom-free interval of over 70 years.
70 years. Incredible.
Amazing persistence, right? Most common in elderly patients who got S. aureus osteo in the pre-antibiotic era.
This brings up a key question. How does the injury type influence risk? In adults, most cases are post-traumatic or post-surgical. Less frequently, late recurrence from childhood hematogenous infections. The risk depends heavily on the fracture type. After a closed fracture, skin intact, implant infection occurs in 1%. In contrast, after an open fracture, bone exposed, the risk ranges from 2% up to 30%. Depends on tissue damage, severity, and time to definitive treatment.
Huge difference between open and closed fractures. Time is critical. What are the common microorganisms in long bone infections? Our source says the spectrum causing hematogenous long bone osteo doesn't differ much from vertebral osteo S. Aureus is most common in both.
S. aureus again. Seems to like bone.
It does. In rare cases, especially in endemic regions or immunocompromised patients, HIV, transplant, mycobacteria, or fungi, Cryptococcus, Porothrix, Blastomyces, coccidioids, can be found. Need to consider travel and immune status. For implant-associated osteo in long bones, coagulase-negative staph are the second most common after S. aureus.
So those contaminants are important with hardware here too.
Definitely. After an open fracture, contiguous long bone osteo is typically caused by gram-negative bacilli or often a polymicrobial mixture. Makes treatment more complex.
A fascinating aspect here are the varied ways long bone osteo presents clinically, from subtle pain to visible infection. In adults with primary or recurrent hematogenous long bone osteo, leading symptoms are usually pain and low-grade fever, often less dramatic than an acute surgical site infection.
More subtle onset, maybe.
Often, yes. Exogenous infection can be classified as early, acute 3 weeks, delayed 3-10 weeks, or late, chronic. Early acute long bone osteo manifests as signs of surgical site infection, erythema, impaired wound healing. Acute implant infection can also follow hematogenous seeding anytime after implant with new pain and sepsis signs. Delayed or late, chronic infections are usually caused by low virulence organisms or occur after ineffective treatment of early infection. Patients might present with persisting pain, subtle local inflammation, intermittent pus discharge, or fluctuating redness over the scar, like in the source figure showing a sinus tract.
Those chronic signs sound easy to miss.
Very easy. Requires high suspicion.
So what does this mean for diagnosis, especially with implants complicating things? The workup for acute hematogenous long bone osteo is similar to vertebral, ESR, CRP, blood cultures, but implants change imaging significantly. Bone remodeling increases marker uptake on bone scans for at least a year after surgery. So a 3-phase bone scan is not useful during this interval, too many false positives.
Right, can't tell healing from infection early on.
Exactly. But for late recurrences, 1 year, it becomes useful and low cost. If positive, CT is needed to estimate extent and detect sequestra, dead bone. Implant infection should be suspected if CRP doesn't normalize or rises after an initial decrease. That's a key lab indicator.
Watch that CRP closely.
Yes. Clinical and lab suspicion should prompt surgical exploration and sampling. For osteo 1-year duration, SPECT-CT is a good option, using labeled leukocytes or antibodies to granulocytes. Ultimately, surgical debridement is often needed for both diagnosis, biopsy culture, histology, and therapy, removing infected material. Surgery is often indispensable.
Connecting this to the big picture, treatment strategies are heavily influenced by implants and chronicity. For acute hematogenous infection in long bones, no implant early, treatment is identical to acute vertebral osteo, usually 4 to 6 weeks of antibiotics. If soft tissue is good and no sequester or implants, generally no surgery needed. Antibiotics alone can work.
So surgery isn't always needed for the acute ones.
Not if caught early and uncomplicated. Oral treatment can be given if an excellent oral regimen is available. Initial 4V course can be short if the bug and susceptibility are known. However, in recurrences of chronic osteo and in all types of exogenous osteo, acute, chronic, with or without implant, a combination of surgical debridement, obliterating dead space, and long-term antibiotics is required. Length of therapy depends on how completely the surgery removes sequestra, implants, and necrotic tissue.
So chronic or exogenous always needs surgery plus long antibiotics.
That's the standard approach. For internal fixation devices, plates, screws, the goals are fracture consolidation and preventing chronic osteo. Stable implants can often be maintained unless the patient has uncontrolled sepsis. The cure rate for early staph implant infections treated with a fluoroquinolone plus rifampin is 90%. Rifampin works well against staph biofilms, E3 weeks old. Fluoroquinolones work against gram-negative biofilms.
Rifampin is key for early staph biofilms then.
Crucial. In these cases, a short initial IV beta-lactam course might minimize resistance to the oral drugs. Total treatment is 3 months, and the device can often be retained even after stopping antibiotics. A good outcome.
But what if the bacteria are resistant to those key drugs?
Then it's tougher. In cases with rifampin-resistant staph or fluoroquinolone-resistant gram-negatives, all hardware should ideally be removed after fracture consolidation and before stopping antibiotics. If hardware must stay, patients get long-term oral suppressive therapy while the hardware is retained. Goal is control, not cure.
So what does this all mean for patients if the infection persists or recurs? The main complication is persistence with progression to chronic osteomyelitis. That's what everyone tries to avoid.
The dreaded chronic state.
Exactly. Risk is especially high after internal fixation of open fractures and in implant osteo treated without adequate debridement. If dead infected tissue isn't removed, it festers. Long-standing osteo with recurrent sinus tracts causes severe skin soft tissue damage, like in figure 131-2. Patients with chronic open wounds often need combined orthopedic repair and plastic reconstructive surgery, a major undertaking.
Does geography play a role here too? Yes. In North America, Western Europe, tuberculous osteo of long bones is extremely rare, mainly very old or immunocompromised. In contrast, in high TB prevalence countries, India, Indonesia, China, tuberculous osteo must routinely be considered. Again, travel history and origin are vital clues. Deep Dive 3, periprosthetic joint infection, PJI, the implant's vulnerability.
Moving on to a particularly challenging area, infections around artificial joints. Periprosthetic joint infection, PJI. Why are these implants so vulnerable? Our source explains, implanted foreign material is highly susceptible due to local immunodeficiency around the device itself. The body's defenses are weaker right at the implant interface.
Like a blind spot for the immune system.
Kind of. Infection occurs via exogenous surgery or hematogenous bloodstream routes. Rarely, contiguous spread from adjacent osteo or deep soft tissue infection. A key factor. Foreign devices get coated with host proteins like fibronectin. This favors staph adherence and biofilm formation, that bacterial fortress.
Ah, the biofilm again. It makes eradication incredibly hard.
Exactly, like a fortress right on the implant.
What's fascinating here is how PJI risk varies not just by joint, but also over time since implantation. Risk in the first 2 post-op years varies. Lowest after hip knee, 0.3 to 1.5%. Highest after ankle elbow, 4–10%.
Wow, big difference between joints. Any idea why?
Likely reflects joint complexity, biomechanics, surrounding soft tissue, all influencing infection propensity. Risk of hematogenous PJI is highest early post-op. However, seeding can occur throughout life, so most cases actually develop more than 2 years after implantation.
So it's a lifelong risk from bloodstream infections.
It is, and the rate of risk for secondary PJI during S. aureus bacteremia is significant, 30–40%. If a patient with a joint replacement gets S. aureus in their blood, there's a high chance it seeds the joint.
That's alarming. Shows why treating S. aureus bacteremia aggressively is critical in these patients, and what kinds of microorganisms typically cause these complex joint infections. Staphylococcus are the major players, 50–70% of PJI cases. S. aureus and coag-negative staph.
Staph dominate here too.
They do. Streptococcus account for 6–10%, gram-negatives 4–10%, the rest various others, fungi, mycobacteria. Some centers see more gram-negatives for unknown reasons. C. acnes causes up to 1/3 of periprosthetic shoulder infections.
Interesting niche for C. acnes in the shoulder. This raises an important question. How do we classify PJI, and what specific clinical signs do we look for? Traditionally, by time. Early, 3 months post-op, delayed, 3 to 24 months, or late, 2 years. However, for therapeutic decisions, it's more useful to classify PJI as 1. Acute hematogenous PJI, 3-week symptoms. 2. Early post-interventional PJI within 1 month after surgery. 3. Chronic PJI, 3-week symptoms.
So classification focuses more on the nature and timing of symptoms for treatment planning.
Exactly. Acute exogenous PJI typically presents with local signs of infection, redness, swelling, drainage, like in figure 131.3. Acute hematogenous PJI, often S. aureus, characterized by new onset pain. Local inflammatory signs rare in hip PJI, frequent in knee PJI. Fever rare after initial bacteremia phase. Chronic PJI. Key findings are joint effusion, local pain, implant loosening, maybe a sinus tract, most commonly caused by low-virulence bugs like coag-negative staph or C. acnes, characterized by nonspecific symptoms like chronic pain, low-grade inflammation, early loosening.
That chronic pain sounds hard to distinguish from just mechanical loosening.
Extremely difficult. A major diagnostic challenge in chronic PJI.
Given the nonspecific symptoms, how do clinicians diagnose PJI, especially when implants create imaging challenges? Requires a multi-pronged approach. Blood tests, CRP, AR, and ESR, 30 milliliter, are sensitive, 91 to 97%, but not specific, 70 to 78%. Often elevated, but could be for other reasons.
Good for screening, not confirming.
Right. Synovial fluid analysis from the joint is much better. Cell counts are 90% sensitive and specific. Thresholds, 1,700 leukocytes in knee PJI, 4,200 in hip PJI. Biomarkers. Alpha defensin in synovial fluid is highly specific, useful for confirming PJI, but expensive, limited sensitivity, so not for screening.
A confirmatory test, then.
Yes. During debridement surgery, get at least 3, optimally 6, tissue samples for culture histology. If implant removed, sonication of material helps detect biofilm organisms. Imaging. 3-phase bone scan, very sensitive but not specific. Not useful for at least the first year post-op. Can't differentiate remodeling infection. CT and MRI detect soft tissue infection, loosening, erosion, but metal artifacts limit their use significantly.
Metal messes up the pictures.
Big time. 18F FDG-PT is an alternative.
Excessive.
Good sensitivity, low specificity. Useful only in excluding PJI if negative, not confirming it if positive.
Connecting this to the bigger picture, treating PJI is complex, truly highlighting the need for a multidisciplinary team. Experienced orthopedic surgeon, ID specialist, maybe plastic surgeon, microbiologist. Most patients referred to specialized centers.
It's like a village to treat PJI.
It really does. General goal is cure.
Yeah.
Pain-free, functional joint, pathogen eradicated. But for patients with severe comorbidity, lifelong suppressive antimicrobial therapy might be preferred. Rule of thumb: antimicrobial therapy without surgery is not curative, merely suppressive.
Surgery is almost always part of the cure.
Generally, yes. 4 curative surgical options. 1. Debridement and implant retention, DAR. 2. One-stage exchange. 3. Two-stage exchange, most common. 4. Implant removal without replacement or section arthroplasty. Implant retention, DIR, offers good chance, 80% only if specific conditions met. 1. Acute infection. 2. Stable implant. 3. Pathogen susceptible to biofilm active agent, table 131-2. 4. Good skin soft tissue. If not, success drops.
Very strict criteria for keeping the implant.
Very. Antimicrobial therapy follows specific protocols, table 131-2. Initial 4, then long-term oral. Rifampin, crucial for susceptible staph biofilms, always combined with another drug due to resistance risk. Fluoroquinolones for gram-negative biofilms if retaining implant. Prevention point. Hematogenous seeding can occur throughout life, highest risk during S. aureus bacteremia. So, documented bacterial infections should be promptly treated in patients with prosthetic joints.
Makes sense. But what about dental procedures? Used to give antibiotics for that, right?
Yes, common practice or consideration. But a prospective case control study showed risk of hip-knee PJI is not increased following dental procedures. So antibiotic prophylaxis is not needed during routine dental work.
Interesting. Why a change?
Probably lack of strong evidence connecting routine dental work to PJI in large studies, plus growing awareness of antibiotic stewardship, avoiding unnecessary antibiotic use. Practice evolves with evidence.
And globally, the PJI landscape is shifting, especially with resistance. Rifampin and fluoroquinolones are the main biofilm-active drugs for staph and gram-negatives, respectively.
Are key weapons against biofilms.
Yes. So in countries with high rates of resistance to these drugs, debridement with implant retention, DAR, generally doesn't yield good cure rates.
Meaning more aggressive surgery like two-stage exchange is needed more often in those regions.
Exactly. A direct consequence of resistance impacting treatment options. 6. Deep Dive 4. Sternal osteomyelitis post-surgical challenges. Let's turn to the breastbone, the sternum, and its vulnerability, particularly after surgery. Sternal osteomyelitis occurs primarily after sternal surgery. Exogenous organisms enter wound, more rarely by hematogenous seeding or contiguous extension from adjacent sternocostal arthritis.
Mostly follows surgery then.
Primarily. Exogenous sternal osteo after open sternal surgery is also called deep sternal wound infection. Can also follow minor sternal trauma, fracture, manubriosternal septic arthritis. Tuberculous sternal osteo typically manifests during hematogenous seeding in kids or as reactivated infection in adults, sometimes preceded by blunt trauma, rarely from continuous infection from infected internal mammary lymph node.
How common is this, and what are the risk factors? Incidence of post-sternotomy wound infection varies, 0.52%, but figures higher with risk factors. Diabetes, obesity, chronic renal failure, emergency surgery, bilateral internal mammary artery grafts, re-exploration for bleeding.
So certain patients are much higher risk after heart surgery.
Definitely. Rapid diagnosis and correct management of superficial sternal wound infection are crucial to prevent progression to deep osteomyelitis. Primary hematogenous sternal osteo is rare, only 0.3% of all osteo cases. Risk factors include IV drug use, HIV, radiotherapy, blunt trauma, CPR, alcohol abuse, liver cirrhosis, hemoglobinopathy.
What's fascinating here is the diversity of microbes, including a significant polymicrobial component. Post-sternotomy osteo generally caused by coagulus-negative staph, 40 to 60%, S. aureus, 10-20%, gram-negative, 15 to 25%, or C. acnes, 2-10%. Fungi, candida also play a role.
Coag-negative staph are very common here.
The most common, it seems. Approximately 20% of cases are polymicrobial, indicative of exogenous superinfection during therapy. Hematogenous sternal osteo, most commonly caused by S. aureus. Others in special populations. P. aeruginosa in IV drug users, Salmonella in sickle cell anemia, M. tuberculosis in patients from endemic areas. Need to consider patient context.
So how does it present clinically, and how is it distinguished from mimics? Exogenous sternal osteo manifests as fever, increased local pain, erythema, wound discharge, and sternal instability.
Sternal instability.
That sounds serious.
It is. A feared complication is contiguous mediastinitis, infection of chest center, occurs in 10–30% of patients with sternal osteo. Hematogenous sternal osteo characterized by sternal pain, swelling, erythema, and most patients have systemic signs symptoms of sepsis. Differential diagnosis includes immunologic processes mimicking infection like Sappho syndrome, synovitis, acne, pustulosis, hyperostosis, osteitis. Differentiating sterile inflammation from infection is critical.
How do clinicians diagnose this intricate infection? In primary sternal osteo, workup similar to other hematogenous osteo, labs, blood cultures, imaging. If patient grew up where TB is endemic, specific workup for mycobacteria needed, especially if onset after blunt sternal trauma. In secondary sternal osteo, post-op, leukocyte counts may be normal, but CRP level usually 100 milligl. CRP is very sensitive here.
High CRP is a big clue post-sternotomy.
Absolutely. Tissue sampling for micro is crucial. In osteo associated with sternal wires, low virulence bugs like coag-neg staph, important. Need at least 3 deep biopsies to differentiate colonization versus infection. Superficial swabs, unreliable.
Gotta get deep samples.
Yes. Imaging. No studies compared modalities specifically for primary sternal osteo, but MRI is current gold standard for all osteotypes.
Connecting to the bigger picture, treatment is aggressive. Combined surgery and prolonged antibiotics. Significant implications. In deep sternal wound infection, combined approach required. Start antibiotics immediately after sampling to control sepsis. Initial empirical treatment should cover staph, consider local resistance, high MRSA prevalence areas. Add vancomycin or daptomycin to broad beta-lactam. Optimize and narrow once cultures are back. Tables 131-1, 131-2 guide choices. A recent observational study found rifampin-containing regimen predictive of success in staph deep sternal wound infection.
Rifampin again showing its value. How long is treatment?
Optimal duration not established. Acute sternal osteo without hardware. 6-week courses rule. Patients with remaining sternal wires, generally prolonged to 3 months. Table 131-2. Tuberculous sternal osteo, 6–12 months.
And surgery. Always needed.
Primary sternal osteo can generally be treated without surgery. In contrast, secondary sternal osteo, post-op, debridement is always required. Needs experienced surgical team. Mediastinitis, bone infection, skin soft tissue damage. Prognosis. Primary sternal osteo minimal mortality risk. Secondary sternal osteo after surgery. High in-hospital mortality, 15–30%.
15–30% mortality. That's incredibly high. For such high stakes, what steps can minimize these risks preemptively?
Good question. Meticulous surgical technique, aggressive management of superficial wounds, optimizing comorbidities, diabetes, obesity before surgery, appropriate perioperative antibiotics. Proactive measures are key.
And once again, global factors matter. In endemic areas, consider M. tuberculosis, Salmonella brucella during sampling. 7. Deep dive 5. Foot osteomyelitis, the diabetic foot's peril. Our final deep dive. The foot, common site for osteo, especially impacting individuals with diabetes. Why is the foot so susceptible? Osteofoot usually occurs in patients with diabetes, peripheral arterial insufficiency, or peripheral neuropathy and after foot surgery, often linked, especially in diabetic patients with late complications.
The trifecta of diabetes, poor circulation, and nerve damage.
Exactly. Can also be implant-associated osteo after foot surgery, hallux valgus, arthrodesis, ankle replacement. Foot osteo acquired almost exclusively by exogenous rote complication of deep pressure ulcers, impaired wound healing. Direct infection from outside, not usually bloodstream.
What's fascinating here is the sheer incidence in diabetic populations and the significant link to amputation risk. Incidence of diabetic foot infection. 30–40 cases per few thousand persons with diabetes per year. High.
Huge number.
Typically starts with skin soft tissue lesions, progresses to osteo, especially with additional risk factors. About 20–60% of patients with diabetic foot infection have confirmed osteo, significantly increasing amputation risk. However, adequate management of early-stage diabetic foot infections can significantly lower amputation rate. Early detection and care are vital.
So what are those specific risk factors making a diabetic foot so vulnerable? Creates a perfect storm. 1. Peripheral motor, sensory, autonomic neuropathy. Can't feel injury, abnormal mechanics. 2. Neuro-osteoorthopathic deformities, KG Charcot foot, figure 131.5, bone destruction, collapse, abnormal pressure.
Charcot foot is devastating.
It is. 3. Arterial insufficiency, poor blood flow hinders healing, immune response. 4. Uncontrolled hyperglycemia, impairs immune function. 5. Disabilities like reduced vision, can't inspect feet. 6. Maladaptive behavior, ignoring wounds, delaying care, allows minor infections to become severe.
This raises a critical question. How reliable are cultures from the foot, given wound complexity? Correlation between bone biopsy cultures and wound swabs, deep soft tissue punctures, is poor, only 24% in one study.
Only 24% agreement, that's terrible.
It's a major problem. Correlation better for S. aureus, 40–50%, than anaerobes, 20–35%. Gram-negatives, 20–30%, or Cograg-neg staff, 0–20%. When considering only bone biopsy samples, most reliable. S. aureus, 30–50%, streptococci, 15–20%, anaerobes, 5–20%, various gram-negatives, 18–40%. Distribution depends on prior antibiotic treatment. Anaerobes prevalent in chronic wounds. Pretreatment selects for P. aeruginosus, MRSA, and Duracocci.
So surface cultures are often misleading. Ideally need a bone biopsy. So what does this mean for diagnosis? Can clinicians rely on the simple probe-to-bone test? In many cases, yes, foot osteo can be diagnosed clinically, sometimes without imaging. Most clinicians rely on probe-to-bone, positive predictive value, 90% in high pretest probability populations, e.g. diabetic hospitalized for chronic deep foot ulcer. If bone felt with metal probe, osteo, highly probable, simple but powerful.
A useful bedside tool in the right context.
Yes. In lower pretest probability patient, MRI should be performed. High sensitivity, 80–100%, and specificity, 80–90%. Preferred imaging? Plain radiography has lower sensitivity specificity, but may be considered for follow-up of confirmed diabetic foot osteo.
Connecting to the big picture, treatment emphasizes both surgical debridement and carefully selected antibiotic therapy. Duration is critical. As mentioned, correlation between bone and surface culture is poor, so treatment ideally based on bone culture. If no biopsy, empirical therapy based on common agent syndrome needed. Broad coverage often.
So biopsy guides targeted therapy if possible.
Ideally. A controlled trial showed no difference between 6-week and 12-week antibiotic course in diabetics where no infected bone needed resection. Suggests shorter course may be adequate sometimes. Wound debridement combined with 4 to 6 week antibiotic course can render amputation unnecessary in about 2/3 of patients. Powerful combination.
Limb salvage is often possible with the right approach.
Yes. The 2012 IDSA guidelines for diabetic foot infections are key. Clinically infected ulcer. Prompt empirical antibiotics may prevent progression to osteo. High MRSA risk include agent active against it, for example, vancomycin. No recent antibiotics. Cover gram-positives, e.g. clindamycin, amsulbactam. Recent antibiotics. broadened to include gram-negatives, for example, Clinda plus fluoroquinolone, Pseudomonas risk factors, colonization, warm climate, water exposure, add anti-pseudomonal agent, for example, piptazo, cefepime.
Very structured empirical approach based on risk.
Yes, if osteosuspected, probe to bone, MRI, bone biopsy should be performed. If infected bone not entirely removed surgically, treat 4 to 6 weeks based on identified pathogen susceptibility. Initial 4, transition to oral based on bioavailability. If dead bone cannot be removed, consider long-term therapy, at least 3 months. Cure often the exception here. Repetitive suppressive treatment may be needed. Goal shifts to control and preservation.
And finally, a concerning global trend impacting foot osteomyelitis, increasing multi-resistant microorganisms.
The resistance problem is everywhere.
Prevalence of MRSA in diabetic foot infections, 543% in various countries. A study from India. 69% of aerobic gram-negatives produced ESBL enzyme, breaking down many antibiotics. 43% of SREs were MRFA.
Those are shocking numbers. Makes treatment incredibly difficult.
It does. This rising tide challenges effective treatment globally, necessitating careful local surveillance, infection control, and antibiotic stewardship. Conclusion and final thoughts. What an intensive and truly deep dive. We've navigated the intricate landscape of osteomyelitis, gaining a comprehensive understanding of its diverse origins, varied presentations, and complex diagnostic and treatment challenges. From spine to long bones, prosthetic joints, the diabetic foot, it's clear this is far from simple. We really aim to master this like the pros, using our source.
Indeed. We've seen how critical multidisciplinary care is, how expert opinion often guides treatment when trials are scarce, and how factors like implants or dead bone fundamentally alter strategy. Those nuances, like poor correlation of foot swabs with bone cultures, highlight the need for precise diagnostics and deep understanding.
So, as we wrap up, what does this mean for the future? Given rising resistance and more implants, how might diagnostics and treatment evolve in the next decade to truly master this? Will we see faster bedside microbial ID, novel ways to tackle biofilms beyond current tools? It's a huge evolving challenge.
Definitely a field to watch. The need for innovation is clear.
Thank you for joining us on this deep dive. We hope this exploration has given you a truly profound understanding and some genuine aha moments. Keep digging, keep learning, and stay well informed.